Everyone. Sorry, I can't actually see anyone through here. So if you have any questions, please pop in the chat or just stop me. Happy to answer questions as we go along. So a little bit about me. I'm Emmanuel. I've sort of started at Warwick about just 2.5 years ago, and recently started my practice at Nuffield. I trained in Oxford, did my higher specialty training there, did my PhD and my advanced endoscopy fellowship there. But I live locally in Leamington Spa and decided I was tired of the commute, so I've taken up a job more locally. At Warwick Hospital, I do general gastro work, hepatology, and ERCP in the US. So happy to answer any questions as we go along. If you have anything about the talk, or we can have a chat at the end as well. So I chose liver enzymes to talk about today. We're going to look at the background to liver diseases and why LFTs feature into that. And then talk about a little bit about sort of learning together on how we approach abnormal liver enzymes. I think I'll be interested to hear your thoughts and on how things are in primary care, just so we can understand together. Common patterns of abnormal LFTs and the more common causes that we get advice and guidance for or referrals for. And finally, finish off with some local referral pathways that are already in place and in development as well. So this is why I'm interested in liver disease. This is a paper from Lancet about over a decade ago, showing very clearly that it's quite an under-recognized cause of preventable problems for our patients, really, in the UK. As you can see, is one of the largest causes of premature death, particularly in young patients as well. And it's the only sort of chronic condition with an increasing death rate. And this still holds true now, a decade later. But the issue here is, the patients are between primary care and secondary care. From your point of view, you want to know what the cause of the abnormal LFTs are. Do you need to do anything and how it's going to affect your management for the patients? From the hepatologist point of view, we are very keen on working out which patient groups have got specific liver diseases that we can intervene with, and detection of liver fibrosis is key because that will be your main predictor of progression of disease, and mainly interested in the cirrhosis follow-up. So you can see that patients don't neatly fall into either one of these categories, and so trying to unpick things is quite difficult. How much of it is acute, how much of it is chronic? And that's where I think working together is important to work out which patients will benefit from seeing us and who are better off being in primary care, getting your input on that. The whole big problem is the paradox with LFTs. As you know, liver function test doesn't always measure the function of the liver. And normal liver enzymes, or LFTs, doesn't always mean normal liver. Abnormal LFTs doesn't always mean liver disease either. There are other causes for abnormal LFTs, as you and I know. And sometimes we get a bit fixated on the size of the abnormality. In some instances, it may matter, but it doesn't always matter. If the ALT is over 1,000 in hepatitis A, that's less of a problem than sometimes in somebody with, say, liver cirrhosis and a normal ALT. So I think that's where the problems arise with LFTs, because we can't really work out a way. It's not predictable like a renal function that gradually declines. And neither is it a specific diagnostic test or nor is it an exclusion tool that you can use. The ALFI project was a project done sort of up north in Tayside in Scotland, where they looked at nearly over 25,000 patients, and less than 4% who had abnormal LFTs actually had significant liver disease within 5 years. So a lot of work for very little gain. So it's about targeting who we need to put our efforts on and who we think can wait, essentially. So just a little bit of recap about what liver injury and liver function is. This is, again, just a sort of a reminder to us that the LFTs, the ALT is present in the hepatocytes and are released when the hepatocytes are injured. AST will be the same. ALT is actually more useful in liver injury than AST, because AST is present also in cardiac and skeletal muscles and can be raised due to that. But the ratio between AST and ALT can be helpful to predict severity of liver disease, particularly in alcohol. Alkaline phosphatase, ALP, is produced in the biliary epithelium, and therefore any disease process that affects the bile ducts gallbladder can sometimes will cause ALP to go up. Gamma GT is done a lot because there is some data on it being quite prognostic in liver disease, particularly in pediatric population, but also in adults. But it's abundant in the liver, but not found in the bone. But it's not specific to the liver either. It can be raised in other conditions, and we'll go through some of that as well. Sorry, was there a question? I'll carry on. Mel and Vicky, please do stop me if there's a question in the box because I can't see the box. The liver function tests, as you and I know, are measured by the prothrombin time, INR, and albumin, and also conjugated bilirubin. Now, if any of the liver function tests is deranged, then it becomes more urgent, and we would like to see them much sooner if there is synthetic liver dysfunction. And lastly, before I move away from LFTs, platelet count is very useful in liver diseases. It's one of the most common hematological abnormality that is reduced in liver disease. And it's normally due to splenic sequestration because of splenomegaly. You get increased destruction of platelets. So it's one of the most sensitive marker for portal hypertension. So it's something that we rely on a lot to work out the severity of liver disease as well. So what is my approach to abnormal liver enzymes? So the first thing I do is actually check historical LFTs. And I know there are logistical problems of you accessing some of our blood tests and us accessing some of your blood tests. And again, this is where I think working together is quite helpful because I think one of the key things in LFTs is working out whether it's acute or chronic and whether this is something that's a blip or has been going on for a long time. Next, we're going to identify the pattern of the elevation, which I'll go through in my next slide in terms of working out how you determine if something has got a hepatocellular, cholestatic, mixed or isolated picture. And then trying to work out what is the context these LFTs were done. And very often we get referrals for incidental findings when somebody has a surveillance or a routine check. And what do you do in that context versus when they have symptoms. As you and I know, the red flag symptoms are things like jaundice, and if you find hepatomegaly or splenomegaly, low platelet count, or any of the deranged synthetic functions, so INR, PT, or albumin, then that becomes more urgent. And I find that most of the time there are clues in their past medical history or previous encounters and their medication history that sometimes points you towards the cause for the liver enzyme to be deranged. And then I sort of work out whether I need to do an acute or chronic liver screen because they are different. And that's why the first question is working out whether it's acute or chronic. So I find this quite helpful doing the R factor. I think we all kind of do it in our heads anyway about how to determine the predominance of the liver injury. And this is simply taking the ALT of the patient, dividing it by the ALT, upper limit normal of the ALT. And then dividing that by the sum of the ALP divided by the upper limit normal of the ALP. So essentially, it just gives us a little bit of a clue whether this is predominantly a hepatic picture, so hepatocellular. If the R factor is more than 5, then it's more likely to be hepatocellular in origin, and there's a list of differentials that we can go through with that. And if the R factor is less than 2, i.e. it was more likely to be cholestatic, so we're looking more at the gallbladder bile duct injury. And most of the time, we do find that it's a mixed picture and working out which one is more predominant, but based on the upper limit of normal. So sometimes you see a mixed picture with the ALT being 5 times the upper limit of normal and the ALP being only twice the upper limit of normal, and therefore we say it's predominantly hepatocellular. I find it quite helpful to sort of work out differentials based on that. So we'll go into specific liver enzyme derangement. One of the things that we see sometimes is isolated raised total bilirubin count, but the liver enzymes, the ALP and ALT, are normal. So it's helpful to check the historical LFTs in this case, because has it been raised before, and has there been a split bilirubin to work out how much of it is conjugated and how much of it is unconjugated. And if it is unconjugated predominant, then we do have to think about causes outside the liver as well, because it's liver, as you and I know, one of the functions of the liver is to conjugate the bilirubin, and conjugation is one of the processes that occurs in the liver. So if it's an unconjugated predominance, we're looking for hemolysis as one of the predominant causes. So if they have anemia, then I would add on haptoglobin and LDH, do a reticulocyte count and a blood film to look for any evidence of hemolysis. And if they have a recent hematoma, and if the hematoma is resorbing, you will start getting unconjugated hyperbilirubinemia. Certain drugs, which we don't use that often, maybe apart from sulfasalazine, can cause isolated raised bilirubin. But as you guess, the most common cause of unconjugated hyperbilirubinemia is Gilbert's syndrome. So I've just put a example of an LFTs there. I, again, can't see the chat. So if anybody wants to comment on what they think could be going on here. So I've given your bilirubin of 107, ALP and ALT is normal, and quite helpfully, the lab has given you the ratio of conjugated bilirubin there. Any comments on this liver enzymes?
I'm waiting. Anybody got any comments? Are they jaundiced?
Okay, it's a couple of comments. So one of them is, are they jaundiced? Oh, you're on mute, Emmanuel. Still on mute?
Right, can you hear me now?
That's it, yeah, perfect.
I'll have to go back.
Okay,
Yeah.
so a few questions, or a few answers even. Are they jaundiced? I expect them to be.
Yep.
Almost all unconjugated
Unconjugated,
and
yep.
normal ALP/ALT.
Yep.
And what is the full blood count?
Good question.
Likely Gilbert's, but usually the above questions. And then someone else has put Gilbert as well.
No, very good thought. I think the key thing here is asking for the full blood count. I completely agree. But the bilirubin is too high for my liking for Gilbert syndrome. And the point I was trying to make here is, yes, it will fit with Gilbert syndrome if the hemoglobin count is normal and we've excluded hemolysis, then yes, I would say this could be Gilbert's. But actually, this is from a patient who didn't have Gilbert's. When we did her full blood count, her hemoglobin was slightly low and her hepatoglobin was slightly low. She ended up having a hereditary spherocytosis, which is one of the, so we ended up referring her to the hematologist in the end, because this level of bilirubin is too high for Gilbert syndrome. So going back to Gilbert syndrome, so if you look at the LFT pattern down at the bottom of this screen, that is more in keeping with Gilbert. So it's normally sort of won't exceed about 70 at most, 80 or 90 is pushing it to the Gilbert's as well. So it's helpful to think about an alternative course if the bilirubin is too high. But if it's within sort of 20 to 70, we'd say, then it is more likely to be Gilbert syndrome. We don't do genetic testing for this. It's purely just based on the ratio of conjugated and unconjugated bilirubin. And it can go up and down during intercurrent illness. So what I would do in the first instance is to wait and repeat, and making sure there's no other intercurrent illness, no fasting or strenuous exercises or starvation period. And so it's important to sort of check all of those things first. And once we've had 2 blood tests confirming that this is unconjugated hyperbilirubinemia, and we've excluded hemolysis and no other causes, then I think it's fair to say we can reassure the patient and no further investigations required. But the key thing here is to inform the patient that forever, in whatever blood test we do in the future, people will be concerned with just seeing the bilirubin, and therefore the responsibility falls on the patient to tell everyone else that they have Gilbert syndrome, so that you don't get sidetracked. I recently saw a patient in clinic, even just last week, who ended up having quite a lot of investigation, including an ultrasound MRCP as well, And actually, it was all GBS in the beginning. And you can see a historical blood test from 2020 that showed that the bilirubin was already raised then. So I think it's important to bear in mind and reassure patients to avoid any unnecessary investigations.
We have another question.
Yep, sorry.
Are people jaundiced if they have hemolytic anemia given raised unconjugated hyperbilirubinemia? Did you do that on purpose, Chintan?
So are people jaundiced? Yes, they can be jaundiced with unconjugated. They don't have to be conjugated. So even with unconjugated hyperbilirubinemia from hemolysis or from hematoma, they will be jaundiced. Now, the level of jaundice is different and is working out how jaundice they will be clinically. But yes, they can be. The short answer is yes. So clinical appearance of jaundice is not very helpful to differentiate between the two. However, if they are very jaundiced, i.e. bilirubin more than 100, like you saw in the previous slide, then that would raise more suspicion of it not being Gilbert's. Okay, so if I can move on to the next isolated LFT. So this is a raised gamma GT, which we all know is associated with alcohol consumption. But the important to bear in mind, it doesn't always have to be excess alcohol consumption. It can be moderately raised even with moderate alcohol consumption. And the key thing here is it can take sometimes up to 6 weeks for the gamma GT to normalize after complete abstinence because of the half-life of gamma GT. So if we are rechecking something, first thing to say is gamma GT is never a good test of how much alcohol they're drinking. But if we are choosing to use that as our biomarker, then give it at least 6 weeks washout period before checking that. A better test would be something called CDT, carbohydrate deficient transferrin, to look for recent any alcohol consumption, which we use in Warwick in clinic, but I'm not sure whether it's available in primary care. But remember, gamma GT is abundant in the liver, it's not in the bone. So if you have an isolated ALP rise, that's where gamma GT is quite helpful to know whether the ALP is coming from the liver or from the bone. But I've listed some other causes why a gamma GT will be up there. So we see a lot in patients who have fatty liver and obese, where their gamma GT is raised and they swear by the fact that they don't drink any alcohol. And interestingly, in type 2 diabetes and patients with COPD and those who are on enzyme inducers like phenytoin and carbamazepine, we see a modest elevation in gamma GT as well. So it's important to bear in mind that it's not just alcohol, and sometimes it can be raised for these other reasons. So going on nicely to our isolated raised alkaline phosphatase that I told you about. So I tend to add a gamma GT immediately if I see this, because I need to know whether it's coming from the liver or from the bile duct, essentially. We've had some referrals where the gamma GT wasn't done, and when you add on to gamma GT, it's normal, then they have the wrong specialty, because most often than not, it's in the bone that we look for. And Paget's disease is rising in incidence, so it's helpful to know what their bone profile is looking like. I've listed the other potential sources of ALP, intestine, and hopefully they're not pregnant when they are referred. So if the gamma GT is raised, then we can consider cholestatic causes of liver enzymes. So if we remember, cholestatic liver enzymes are raised ALP and gamma GT, and if we go back to the R factor of less than 2 on our calculation, that gives us an idea that this is cholestatic liver enzymes, and working out whether it is coming from the extrahepatic cause or intrahepatic cause. Now, with the extrahepatic cause, I think it's fairly straightforward. If they're jaundice and raised ALP gamma GT, immediately you're thinking biliary obstruction. Some of it would warrant a 2-week weight referral if you're considering tumor, particularly if they're painless jaundice. And if it's painful, you're thinking about stones. But I want to just highlight some other less common causes.
Can I just ask a quick question?
Yeah.
There's another question that's come in, I think, from the
Yeah.
previous slide.
Okay.
Can statins cause an isolated raised gamma GT?
Not to my knowledge. Statin problem in liver enzymes, you never say never, but I've not come across statin being a common cause for isolated gamma GT in the absence of everything else. No, I'm not aware of that.
Thank you. Sorry to interrupt.
No problem at all. Please do. Ideally, it would be nice to see everyone and make it more interactive, but I have to rely on the chat. Cholangiopathies, which are becoming more and more common now, particularly with ketamine use. So bearing that in mind, we are having a collection of patients in Warwick, and also IgG4 related disease, which is rare. Again, the main thing will be to exclude cancer first. but important to bear in mind that there are other benign conditions that affect the bile ducts, which can cause raised LFTs, ALP and gamma GT. But what is more common that you might see is intrahepatic causes, and the biggest sort of culprit to this is comoxiclav. And we have to remember that it can be 6 to 8 weeks from the time the comoxiclav was started or finished. So the lead time is quite long. So it's important to go back and check if they were not on comoxiclav or any other medication during that time. PBC and PSC is quite rare. PBC is more common. We do see a lot of referrals for PBC. And one of the first signs is isolated gamma GT, can be in PBC too, but more often is alkaline phosphatase that goes with gamma GT. And then there are non-liver causes. So, infections, sepsis, congestive hepatopathy. So if you've got right-sided heart failure and the congestion within the liver, in the sinusoidal sinusoids within the liver, that can raise your ALP as well. So that's increasing what we used to call cardiac cirrhosis back in the day. We're seeing a lot more of that as well on the right side, pressure from the right side of the heart. So the next one is pure hepatitic. So this is when you have raised ALT and AST. I don't believe we get AST routinely. I think it's an add-on. Correct me if I'm wrong. So the R factor here will be 5 or more, which then points us more towards the direction of it being more hepatitic. Therefore, hepatocellular injury, hepatocyte injury within the liver is more likely. Actually, the most common cause for this is, as you know, steatotic liver disease. We're seeing a lot of that with very mild ALT rises in these patients, which is reflective of inflammation from the fat, steatohepatitis sometimes, but not always. Again, DILI is quite common. Again, different antibiotics, different drugs over the counter. I've got a whole slide on DILI coming up. So flucloxacillin, doxycycline are the common ones that we see that causes raised ALT. Nitrofurantoin is another one. We'll come to that in the drug-induced. But virus causes, autoimmune hepatitis causes, this is where your liver screen comes in to look at other causes, primary liver diseases. But don't forget your non-liver causes. I think we do check, I do see celiac TTG being checked quite often, which is good. Thyroid function being checked, which is good. It's helpful to exclude all of those causes so we can concentrate our minds on the liver, on the referral. But we do see a lot more of mixed liver enzymes, to be fair. It's very rare that it's textbooks, pure hepatitic or pure cholestatic. It is a dynamic process. For example, with drug-induced liver injury, which is the most common cause for mixed liver enzymes, it can start off being hepatitic, and then very often it actually becomes more cholestatic, particularly with flucloxacillin and clindamycin, for instance. And this is an example of a patient who was on both flucloxacillin and clindamycin for a soft tissue infection. And you can see that it's a mixed picture of cholestatic and hepatitic. So she started off being more hepatitic and then went towards more cholestatic picture. But not to this level. Steatotic liver disease can also cause mixed liver enzymes and viral hepatitis as well. So just a recap on the difference between acute and chronic liver disease screen. So before I go down that route, are there any questions at all about what we've talked about in terms of the pattern of recognizing liver enzymes?
There is nothing. There's nothing on the chat at the moment.
Okay, great. So I'll carry on. So acute liver screen, I think sometimes we miss out some of these things. So again, the history and working out whether it's acute or chronic, or was it discovered incidentally, is in the context is very important on which tests we do. I think we're very good at doing A, B, and C, but we sometimes forget E, CMV, and EBV in these patients. I guess if there's no preceding viral illnesses, fair enough, we don't really need to go through that. But E, incidence of hepatitis E is rising. And we used to see the ALT being very high in these patients, but these days 200-300 hepatitis E is still possible. So it's worth thinking about it and finding out whether they've eaten sort of uncooked pork or sausages, usually during barbecue seasons when we see that. ANA, immunoglobulins, liver autoantibody screen. I've got a slide on liver antibodies coming up, which I think will be important. So this is mainly to exclude autoimmune hepatitis in your acute liver screen. And if the patient is young, consider Wilson's. Again, very rare. I've only seen 2 Wilson's in my sort of training, and but we do that religiously, but the yield is quite low. Chronic liver disease screen is where we do see most of the positive markers come through. Again, this is just a summary of that. You will have access to this slide, but I won't go through in detail all of this. We do have some slides coming up on this. So a note on liver autoantibodies. So what I've recently learned is in Warwickshire, there are two types of ANA requests. So the standard ANA request that we do is mainly for the chronic connective tissue diseases, and that doesn't always pick up autoimmune hepatitis. And the two ANAs are different assays, and they do different ways in our lab here and also in Coventry. So if we're thinking of autoimmune hepatitis, the ANA to send is the HEP2 ANA and not the connective tissue disease ANA. So that's the first note to consider. So if we are thinking autoimmune hepatitis, we have to send the right ANA. The second thing is about the strength of the titer is not reported locally in our lab. Some labs outside, for example, when I was in Oxford, reported on the strength of the positivity of the ANA or the anti-smooth muscle. Because it's important. If it's a weak positive, say 1 in 40, as opposed to 1 in 320 or 640, that can be just an innocent bystander, and that can be positive in your fatty liver diseases, can be positive in alcohol-related liver diseases, and sometimes for no reason. That is not very diagnostic, 1 in 40, but when 1 in 320 is strongly positive, that is more likely to point you in the direction of autoimmune hepatitis or autoimmune liver diseases. So that's why, in the absence of not having the strength titers, it's important to correlate with the immunoglobulins, the liver enzymes, and the history instead of taking it out of context. So if the immunoglobulins, particularly IgG, is normal in autoimmune hepatitis, with a positive ANA or smooth muscle antibody, and the liver enzymes otherwise, ALT is not that high, and there's no autoimmune history, it's very unlikely that this patient has got autoimmune hepatitis. So again, context is very, very important. And just because one test is positive doesn't mean that they have the disease. So again, that's my last point. Just because the antibody is positive doesn't mean they have the disease. And we often see that in AMA. So you can get antimitochondrial antibody being positive, but actually their ALP and gamma GT is normal. They don't have PBC just because they have the antibody positive. Yes, they could have ALP rising later on in life, in which case we can diagnose them with PBC, but having the antibody on its own does not constitute PBC and does not constitute autoimmune hepatitis. So some of the common sort of non-urgent referrals we get for raised ALT is mainly incidental, and the two most common causes are fatty liver and DILI. So I'm just going to go a little bit more detail for those two conditions. So you may be aware about sort of just under 2 years ago, the nomenclature for fatty liver has changed. We used to call it non-alcoholic fatty liver disease, but we're now calling it what it is rather than what it isn't. So metabolic dysfunction associated steatotic liver disease is MASLD or MASLD, is the terminology for fatty liver from metabolic causes. And on the other side of the spectrum, you have the alcohol-associated or alcohol-related liver disease, ALD, which can also cause fatty liver. And then there's a bit in the middle where a bit of both really contributing to the fatty liver. And majority of our patients we see, most of them fit on one or the other. There's a group that fits in the middle, depending on how much alcohol they drink. And on the far right of the screen, you can see some other rare causes of steatotic liver disease. So fatty liver, the take-home message is not just from metabolic causes. Alcohol causes fatty liver as well as some certain drugs can cause fatty liver. So you need evidence that this patient has got fatty liver, and that's usually an ultrasound scan that first alerts us to the possibility of this patient having fatty liver. And then we need to go through the table on the right-hand side. Do they meet any of these criteria for cardiometabolic syndrome? So as you can see, a lot of other patients would meet at least one of these criteria. So therefore, by definition, they do have steatotic liver disease. And the next thing is to work out what is driving their steatosis. Is it purely a metabolic cause, alcohol, or a combination of the two, or sometimes some other causes? Certainly, certain drugs can do that, particularly if they've been on antipsychotic medications for a long time. That can cause fatty liver too. So it's worth going through some of those sort of causes when you have the time. So fatty liver, MASLD or MASLD. So if you see fatty liver and you think it's predominantly all metabolic, Unfortunately, the lab doesn't give us a FIB4, and this has to be calculated. There's a formula that you can access online. We are working with the lab to try and see whether we can automate a FIB4 and do a reflex testing on AST, adding on AST level when we see an ALT that's raised. So hopefully in the future, you'll be able to get a FIB4 report directly when you request an ALT. So again, bear in mind some of the pitfalls from this is that it's not a reliable test in extremes of ages, as I put there, less than 35 and 65. So they need another test to risk stratify them. But I think the key take-home message that I wanted to get across here is that this graph is taken from a paper recently in Journal of Hepatology. And if you look at the FIB4, which is in pink, high FIB4 has got 15% cumulative incidence of cardiovascular event. So this is the risk of cardiovascular events in 10 years in a large group of patient multi-center study over the course when they follow them up. And you can see the indeterminate FIB4 and the low FIB4, the two lines are very close to each other and actually mirrors the sort of the outcome quite closely. So I don't want to be bogged down too much of us focusing our energy on this low FIB4 and indeterminate FIB4, because we need to, if you remember the first graph I showed you, with the rising incidence and death from premature death from liver disease, we need to identify the high FIB4s, the 15% of that risk that they have, that they've got a 10-year cumulative risk of cardiovascular event. So we need to remember that fatty liver from metabolic cause is not an isolated liver disease, it's part of a bigger systemic problem which links to diabetes, cardiovascular health, and just overall general sort of health of the patient, and their prognosis is very much dependent on their heart rather than their liver disease. And again, if you look at the table on the right-hand side, you can see again, liver-related events, the risk of liver-related events, hepatic decompensation, and HCC is very low on those people with FIB4 that is intermediate or low. And even if they're intermediate and they've got a FibroScan, which is also in the intermediate range, again, the risk is still much lower compared to this group over here. So we need to be focusing on identifying patients who've got a FibroScan of more than 12 and have got a FIB4 of more than 2.67, rather than doing bulk of our work trying to identify this group, because these are the group that are not going to run into trouble. These are the group that we need to be focusing our energy on. So next, fatty liver, I said that can be caused by alcohol as well, so we mustn't forget. We don't use FIB4 for alcohol-related fatty liver disease because it's not validated for that. Although we use it sometimes, it's actually not validated. We should be using the AUDIT-C tool to work out who that should be referred for FibroScan. So nice guidance is that if they've got harmful drinkers over here, which has been defined as 50 units or more in men, 35 units or more in female, those are the ones who are at high risk and they need fibrosis assessment. So again, these are the people that we need to be seeing in secondary care to try and work out, because they are the ones who's going to decompensate and going to run into HCC and chronic liver transplant in the future. So these are the group that we are interested in seeing. And this group, the only proven intervention that's going to work for this group is alcohol abstinence. So yes, we do have some alcohol abstinence services in hospital, but a lot of the alcohol services has been commissioned by CGL and other sort of community-based services. So again, helpful to think about it, think about where this patient will benefit from going to secondary care or these sort of community-based services. So my next sort of two slides are going into DILI. So before we go into DILI, any questions about the fatty liver slides so far?
There's nothing typed into the chat at the moment.
Okay. I've only got a few more slides, I believe, so bear with me. So this is DILI, drug-induced liver injury, which is often idiosyncratic, which means that it can happen for no reason, particular reason, could be okay in one person, but not okay in another individual, and there's completely no rhyme or reason for it. So unless we think, I've just seen a hand pop up from Chintan Shah.
I did want to ask, but I can ask at the end, so don't worry.
Oh, okay, fine. I'm happy to take now or later. I can get through the slides and we can have a chat after. So we've covered the lead time bias. I've sort of told you guys about that. It takes about 6 to 8 weeks sometimes before the LFTs become abnormal. So bear that in mind. I've listed some of the common antibiotics and medications that can cause idiosyncratic DILI. Important to ask about over-the-counter medications. I recently had a patient who was accidentally overdosing on paracetamol because of taking 2 different preparations. So I think it's important to think about and ask about that. But this is what's becoming a hot topic now in the liver world, because these sort of medications that I've listed on the left-hand side, I'm not even going to try and pronounce some of them, in its natural form, they're actually okay. But the problem is we are now starting to put them into capsules and into tablets with 20 other extracts within it. And we're increasingly seeing drug-induced liver injury from some of these herbal remedies and which has been turned into health supplements. So it's helpful to ask them about anything that they've ordered from online, from Amazon, what medications and supplements they're on, but most importantly, when they started it, when they stopped it, and working out the timing with the LFTs, a bit of detective work on that. But if you don't ask, you don't know. I had a patient who, after a year of follow-up in clinic, told me that she had started drinking some tea with some particular leaves, which I then had to look up, which actually does cause liver injury. And on stopping that, everything got better. So it's worth asking this in detail. I think statins, you're much more experienced at statins than I am in terms of when to start and stop. Just a little bit of the summary on the statin-induced liver injury. It is very rare. So I think if the patient needs statin, I would go on the side of actually putting them on statin rather than taking them off the statin. LFTs can go up and down. It can take usually within the first 6 months you see it, but very rarely after that that the LFTs will go off. The guidance is to stop it when the ALT is 3 times the upper limit of normal. And then once we've excluded all the other causes and we're happy that we've excluded all of them, then re-challenge is something that we do need to consider if the patient really needs it. And I've given a sort of a which statin is worse compared to the others. So a little bit of comparison over there. Pravastatin and rosuvastatin are the least enzyme-inducing sort of statin within the liver. They follow a slightly different pathway, and therefore, if we do need to re-challenge or you want to switch to a different statin, that because of LFTs, they are probably safer. But the other thing that increasing the research is showing that just because the LFTs go off when patients start on a statin, it doesn't mean that they are having a liver injury. There's some studies showing that actually it's just the way the metabolism works, that you get initial LFTs going off, and then they do tend to normalize and fixes itself. So it's very difficult to work out whether they fall under liver injury or whether they actually just have liver enzyme derangement, which is just going to sort out by itself. I think the key thing is to work out whether the patient really needs a statin or is there an alternative. So finally going to finish off with some of the pathways that's available. So if the patient meets any of these criteria that I've listed down there, and that means we need to see them sooner rather than later. So then we would consider seeing them on a virtual ward pathway in Warwick, and I'll pick that up from a referral to the acute medicine team. And just on that note, cause of ALT over 1,000, of course, this would be referred on a same-day basis as an acute, either medical team or AEC. But I just wanted to show you one particular case where we got a little bit sidetracked with thinking it being hepatitis, but I put it as number 6 at the bottom, a bile duct stone passage. So when the stone passes through the sphincter or body, you can get a really sort of quick and massive rise in the ALT, which then normalizes very quickly within 24, 48 hours. So I think that's why the history and the context is quite important. And I think we got a little bit sidetracked thinking about hepatitis in this patient, but actually it was never ever hepatitis. It was all in the story of her passing a stone. And lastly, we are developing a direct access FibroScan pathway, so you don't necessarily have to refer it to Warwick Hospital. So this service, hopefully, we are developing and will be available in Stratford Hospital to begin with, mainly to triage our fatty liver patients, again, as I said in the beginning, to try and identify the group at highest risk of having liver-related events and cardiovascular events. And these are the group that we need to be focusing our energy on. So I think we need to have some consultation with primary care colleagues about how we're going to roll out this particular pathway and to get some feedback from the stakeholders. So lastly, some take-home messages. Again, there's quite a few there, but I think the main thing is key things to work out if it's acute or chronic. I think I can't stress that enough, because looking through previous LFTs are key. And very often you see that the ALT has risen before and it's normalized, risen before and normalized. So it's okay to wait a bit and repeat the LFTs and see what happens rather than acting on it immediately, particularly if all the liver screens have already been done. History is probably the most important take-home message. I know we all have limited time in terms of how much history we can take, but it's helpful to sort of go back and ask certain questions as well, particularly with regards to non-prescribed medications. I find the R factor calculation quite helpful to sort of focus my mind on what are my differential diagnosis. And lastly, when it comes to fatty liver, we should be using the FIB4 for metabolic causes and ODIT-C for alcohol-related fatty liver. And lastly, I've jumped from the point about delay, so I'm going to stop there. Lastly, I'm happy to be contacted directly. That's my email address. So if there's any advice or guidance or any questions just to check things, happy to be emailed directly. Or obviously, we do also have the advice and guidance. And for any Nuffield Health referrals, you could refer to, that's the email address to refer the patient to. Great, thank you very much. Happy to take some questions.
Chintan, you asked a question. You asked some questions at the beginning. Have they been answered, or do you want to go back to them?
Just wanted some clarification, please. Thank you for an excellent talk. It was really enlightening. I didn't know GGT could rise in prostate and obesity cases as well. Two questions I had. Fatty liver in primary care, when it's not the high risk FIB4, when it's lower intermediate risk, how often or how frequently would you suggest we monitor them? And what do you suggest we should be monitoring in primary care? So we've already done LFTs, there is slight ALT derangement, the ultrasound shows fatty liver. What next would you suggest? We have addressed the metabolic issues, but how often would we, or how frequently should we be monitoring them?
It's a very good question, actually, because there is no data on it at all. There is no surveillance guidance. There is no guidance on what's going to happen to this patient. So the arbitrary number that has been picked in a consensus statement. So BASIL, which is the British Association of Study of Liver Disease, teamed up with BSG, and they had a panel of experts and consensus statement. There's no clear guidance on this, and there's no evidence-based. But they suggested considering rechecking the FIB4 in 3 years is what they have suggested. So you may see some of our correspondents suggesting that, but again, it's completely arbitrary. And in some patients, you could argue why, because they are already demonstrated that their baseline FIB4 is low, and therefore the graph that I showed you with the cardiovascular events and their liver-related events is going to be so low moving forward. So why are we wasting time bringing them back and rechecking and doing things? So yeah, I can't give you a blanket answer because there's actually no evidence or guidance on that. On a case-by-case basis, if you are concerned about a patient, I think it's helpful to do it in about 2 or 3 years' time.
Thank you. And the second question was, does it matter? Because I think one of your slides did address it about it's those patients who have high BMI but also drink 1 unit of alcohol or 1 glass of wine a week, a day, and it's a mixed picture where the MAS ALD and ALD predominant or MAS, we are not sure. So when we do the MD Calc FIB4 score, it asks whether you want to use the NAFLD calculator or the other one. Is there any suggestion or criteria or what you'd suggest?
So just so I've understood the question correctly. So I think the first part of the question, I didn't really get it, but just correct me if I'm wrong. But second part is between FIB4 and NAFL fibrosis score, FIB4 has got more evidence, so we should be using the FIB4. But in terms of the alcohol intake, it is, again, as you can see there, it's a spectrum of how much alcohol intake it is. So this nomenclature came from America, so they go by grams. Now, in the UK, there is talk about going through grams as well in the future, but at the moment, we're still using units. So if they drink, this is again, because I've done the conversion from grams to units. So if they are drinking, say, more than 50 units a week in men and 35 units a week in women, then they go into here, alcohol-related liver disease. Yeah. If they have less than if they're drinking within the recommended limit, so within the 14 units of alcohol per week in the UK, then they go into this, which is the metabolic dysfunction associated with liver disease. Yeah. Technically, it's actually from 20 units right up to 52 units that fits into this bit. But because the UK guidance is 14 units, for ease, we say, okay, 14 units and below go into this, 35 for men, women, and 50 for men go into this. Anything else comes in the middle. So you'll find that majority of people either will fit into this or this when it comes to alcohol.
Thank you.
And again, the reason why the units for female in America has been maintained is because research have shown that women have got smaller livers, and that's why they have maintained the difference between the units. Whereas in the UK, as you may remember, we had difference as well, but for standardization, we've dropped it down to 14 units.
Thank you. Thank you.
No worries.
Does anyone have any more questions whilst we have our expert here? Well, if there are no more questions, I would just like to say a big thank you to you, Emmanuel. Thank you very much. And also thank you to those of you who joined this evening. You can see that Vicky posted about the feedback form. It would be hugely helpful if you could fill that in. We will send it to you again tomorrow, just in case you don't get a chance now. But thank you ever so much for attending. And I will also send an invitation out to the next lecture for March.